Welcome to Clinical Conversations, a Journal Watch podcast. It's for the week ending August 13th. This is podcast number 97. I'm Joe Elia. We're back after a week off with a conversation about Vena cava filters. Don't fret, it's not a procedural conversation, but one about what happens when these devices are left in and start to break apart. Our interview comes first, and then a look at recent clinical news. You're listening to Clinical Conversations. The current Archives of Internal Medicine has a study on what happens to Vena cava filters over the long term. It turns out that for one brand of filter at least, the news is not reassuring. Researchers followed up on 80 patients who had received one of two kinds of Vena cava filter made by Bard, an earlier model called Recovery and a later version called G2. The patients underwent fluoroscopy to check the filter's status. They found that 16% of the spider-like filters had lost at least one of its legs, or struts. Fully 25% of the earlier models had shed a strut, while about 12% of the later models had. The FDA simultaneously announced that it's studying the problem and is recommending that the filters be removed when their function, protection from pulmonary embolism, is no longer needed. Here to discuss the archives paper with me is Dr. William Nicholson, its first author. He's in the Department of Cardiology at York Hospital in York, Pennsylvania. Welcome, Dr. Nicholson.
Thank you.
I want to ask first, what prompted you to do the study? Was it the patient that you described early on in the article?
It was. We had the opportunity to take care of a patient who had presented initially with some complaints of shortness of breath and hypotension and chest pain that was pleuritic in nature. And we ended up on fluoroscopy seeing that she had fractures from the filter. Ended up in the cardiac silhouette on fluoroscopy, and we ended up doing an ultrasound and echocardiogram, and she ended up having a sizable pericardial effusion and tamponade physiology, and ended up needing emergent open heart surgery to drain the effusion and also to remove. She had three little nitinol struts that had broken off from the filter and gone up and presumably perforated through the right ventricle. And so that prompted us to basically, we had not seen that obviously, and it's not clearly a commonly reported complication. And so we had done a literature search, and we could find two other similar cases that were reported in the literature that were both with the same recovery IVC filter that this patient had. And so it raised our suspicion and concerns, and we basically went back and looked, and nobody had systematically gone back and looked at the filters to determine, was this a more than infrequent event. And so that's what we chose to do, is we went through our local IRB process and tried to contact all the patients at our one center that had received an IVC filter made by Bard. There were two types. There was a recovery, and then there was a G2 filter that had replaced the recovery filter after it was taken off the market for some device modifications.
Mm-hmm. Why do you think those fractures, those filter fractures, of the struts, are so rarely reported?
I think partially it's just I think a lot of patients probably have non-clinical events, meaning that they probably are asymptomatic and don't know about it. And I think a big issue with this is I think people, or at least from our experience here, were not aware that this really was a potential complication that could happen with any type of frequency. So I think people just weren't looking for it. On fluoroscopy, if you hadn't seen this before, I've shown it to quite a number of different colleagues around the country, and most of them don't know what these little fragments are in the heart right away, unless they've seen it before. So it takes some exposure and takes some experience to recognize what you're looking at here. And so I think it just was unrecognized, I think, is really what it amounts to. And certainly, it's not a clinically inconsequential event all the time. And so I think there's probably been clinical scenarios that were unrecognized that may have been a result of the filter fractures and embolization.
Were the findings a surprise?
They were. I was obviously surprised when we had our first patient present, because it was new to me. It was bothersome to me that there were very few reports in the literature, but the other reports were also with the same recovery filter model that Bard had made. So that was a little bit of what prompted our interest in that particular filter, just by pure chance that that was the same filter in other patients that had been reported, and it was also bothersome that that was the filter that was implanted at our center with the most frequency. So that's why we chose to look specifically at that filter, both the first and second generation models of that filter.
Why are the filters left in as long as they are, do you think?
Well, I think it's variable. I think a lot of these patients that get a filter, or a lot of the patients at our center that have gotten filters, quite a few of them are trauma-related patients, and so I think a lot of times those are often young patients and patients that maybe don't have excellent follow-up care after they're treated for the trauma that they come in for, and so I think probably some are lost to follow-up, and I think a lot of patients, despite the fact that it may have been put in with the capability of being retrieved, may or may not have been the intention to retrieve it because they may have had ongoing clinical indications that still need the prophylaxis that the filter was providing for pulmonary emboli, just meaning that their underlying condition that predisposed them may or may not have ever resolved, and so they may still have a true clinical indication to have a filter in place.
But would you guess that many of these have been left in unnecessarily, or have, as you say, the patients have been lost to follow-up?
I don't think I could say one way or the other. I mean, I think, a reasonable, speculation would say that there's probably patients out there that were lost to follow-up, but, I don't know the clinical scenario on each of these patients, obviously. I just know, that these particular patients still have the filter in place. And it's not an uncommon practice. If you look at other reports, we had around a 7% retrieval rate of the potentially retrievable filters. About 7% of those patients actually went on to have the filter recovered. And that's not that all that different from what you see around the country. There's been multiple reports of what kind of frequency do recoverable filters get recovered, and most of those reports are less than 20% of the time.
I went onto the BARD site, and they have a couple of studies on the site, and one of them talked about the attempt to retrieve filters from 100 patients. Of the ones that they did attempt to retrieve it from, I think that the non-recovery rate was something like 5%. So even when you're going in to try to retrieve the filter, 5% of the time, you can't always do it. And I'm wondering whether that in itself is a disincentive for removal.
I think it certainly could play a role. I think there's been multiple reports. Lynch had at Hershey Medical Center up at Penn State had published some series on his success rates with recovering the filters, and I think a lot of it's going to be a little bit operator dependent. He has very high success rates and with very low complication rates, and I think they can be technically challenging, but I think in experienced hands the numbers can be very good and very promising. There's a similar report by Hall that we had cited in our paper where they had seen similar types of patients present. Around 25% of the patients that they had found with the recovery filter had experienced fractures and embolization, and they actually went on to recover all of those patients' remaining filters without complication or difficulty, some with quite extended follow-up time periods between when the filter was implanted and when they chose to recover it. So I think it can be technically challenging. There's no question in some cases are going to be more difficult than others, but I think it seems as though the vast majority of the time in experienced hands it can be done safely and done fairly high success rate.
The mechanism for this strut fracture is metal fatigue, do you think, and is it the pulsatile flow of the blood past the filter that's just deforming the filter slightly, and over time it just sort of works itself loose?
That's what we had speculated. Nitinol notoriously as a product can fracture when you have recurrent stress on it, and so if you have stress on a certain segment and repeatedly do it, I always sort of likened it to a paper clip. If you take it and start to bend it back and forth and back and forth and back and forth, and eventually it'll just break in half. And I think that's likely what we think is going on. I mean, that's a little bit of speculation. Obviously, there's been some studies. Again, Hall had done a nice job of looking at the filters that they had removed under electron microscopy, and they were able to see that there was evidence that they had some metal fatigue at the fracture points. And so it makes sense too, with the fact that the filter fracture rates would go up with time, because he'd be exposed. The longer the device was allowed to dwell in the patient, the longer it would be exposed to those repetitive forces and be more apt to eventually fatigue the metal and fracture. And so I think that's why we see in our study higher rates than what you've seen in other studies or what's been reported in other studies. Most of the other studies, when they talk about the fracture rates, are talking about it in 6 months, because that's typically the time when they're talking about recovering the filter. And we have much longer follow-up where these patients are, for the G2 filter on average, we're right around 24 months, and for the recovery filter, we're up to 50 months. So it's much longer exposure time, I think, that our patients were having, and as a result, I think it sort of continues to argue for the fact that it's probably metal fatigue, but that's not certainly borne out to be shown to be absolutely true.
And the FDA is, as we said, embarking on its own studies of this device class. Are other filters made of nitinol as well?
They are.
They all are. Okay.
I don't know that they all are, but there are certainly other ones that are made of nitinol.
You've stopped using the BARD filters at your institution. Did you devise a new institutional policy on the use and also on the removal of these filters? And if so, would you mind sharing it?
Sure. So just to be clear, so I'm a cardiologist, so I don't put the filters in or recover them. We simply got involved just because of the encounter we had with the one patient, and then just sort of spearheaded looking at the fracture rate. So I would never present myself to be an expert on implanting them or removing them, and the choices of which filters to place and which ones not to place, I think is probably best left to the vascular surgeons and interventional radiologists and those interventional cardiologists that choose the implant to choose. But what we had done is we didn't know whether this was a class effect or whether this was specific to the BARD filters. What we did know is that the numbers we were seeing were unacceptably high for us to be comfortable to keep that as being the filter we used here. So when we had looked at our data after we had seen the patients in recovery in follow-up, we chose at that time when we put the data together to stop implanting the filter there. So we actually had it taken off our shelves and allowed the different operators to choose a different model of what they would like to use, and that's going to be a user-by-user choice. I think people have felt more comfortable with other devices. Some people felt that they'd like to go back to using the devices that were designed to be permanent implants rather than recoverable devices. But I think that's going to be an individual call until people do look at the filter rates of other devices, and again, as I said, determine whether this is a class effect or whether it's unique just to the BARD filters, and that's going to have to be borne out. That's one of the difficulties with finding something that's kind of a new finding, and it's hard to make blanket recommendations as to what to do, but at the same time, I think clearly from our perspective, this wasn't an acceptable option to continue implanting here.
Clinicians who see patients who present with symptoms mysteriously of, say, a tamponade or other symptoms that are suggestive, would you say, suspect or at least look into the record to see whether there is a filter in place?
I think so. I think, in my sort of interpretation of the whole situation, I think it's important to, one, make sure physicians are educated that this is a potential complication that can occur. As I said earlier, it was not something that prior to this study, that if somebody presented with pleuritic chest pain and had a previous DVT and had an IVC filter, a filter fracture and embolization to the heart would not have been, on the top of my differential diagnosis. But clearly, having done this, it's an issue that I think you need to be aware of and recognize that it can happen. I think it's also important to arm the patients with the knowledge too, because I think these patients have had something left or placed in them for an extended period of time, and I think they need to be aware that if they had, it's always worrisome with pleuritic chest pain and shortness of breath, symptoms that you can certainly have with tamponade. It can certainly be the same symptoms you would have with a pulmonary embolus, and so you want to just make sure they know that this is something to alert their treating physician of, that they do have a filter, and it's something that can pretty easily be looked at to determine whether or not it's a a potential cause for their symptoms. These are not terribly difficult to see. They can be hard to see on chest X-ray because the heart's obviously a moving structure, and sometimes it's very hard to see the little nitinol fractures that are in the heart. But if a CAT scan does show it pretty clearly, and certainly fluoroscopy in the cath lab shows it very, very nicely, and it's very easy to see it on fluoroscopy. So I think, it's something that can be looked for without a whole lot of difficulty. And I think, it's something to be aware of, to include in your differential diagnosis in a patient that presents with those type of symptoms.
All right, Dr. Nicholson, that's good advice. Thank you for spending the time with us today.
Sure.
Here's the week's important clinical news. There's a study from the American Journal of Respiratory and Critical Care Medicine linking the use of acetaminophen in adolescents and an increased risk for asthma, rhinoconjunctivitis, and eczema. It's a cross-sectional study based on survey data from 50 countries and over 350,000 subjects. But the numbers mean little if the design is flawed. The authors realize this and call for randomized, controlled trials to check the association more carefully. Next, a worrisome report from Lancet Infectious Diseases details a mutation found among enterobacteria, that is E. coli and K. pneumoniae, that renders them immune to carbapenem-class antibiotics. The mutant gene has been found both on bacterial chromosomes and plasmids, and it produces an enzyme, NDM1, whose full name is New Delhi metallobeta-lactamase 1. It's been found in India and Pakistan, and in the UK, notably among patients who've been to South Asia for elective surgery. Finally, in the week's major stories, here's one from the Archives of Neurology that got a lot of press, and patients may already be asking about it. It seems that Alzheimer's disease leaves a protein signature in the spinal fluid. Assays found the pattern in 90% of Alzheimer's cases, 72% of cases of mild cognitive impairment, and 36% of cognitively normal people. The pattern consists of a low level of beta-amyloid protein and an increased level of phosphorylated tau protein. The authors of an editorial about the research recommend that the analysis be undertaken when a definitive diagnosis will help counsel patients about work and driving. Well, that's it for this week. Let me know what you think. My email address is jelia@jwatch.org. Or you can leave a voicemail at 1-617-440-4374. Earlier podcasts are all available at podcasts.jwatch.org, and the Journal Watch website is jwatch.org, where you'll find almost 25 years of summaries of the most clinically useful research. It's a good resource in an ever-changing clinical landscape. Clinical Conversations executive producer is Adore Yano. I'm Joe Elia. Join us next time, and thanks for listening.